Hello, everybody. My name is Kathy Elf, and I'm the Chief Executive of the Macular Society, and thank you very much indeed for joining us for tonight's virtual clinic. This is our October session, and as you probably know, we've been doing these now for a little over a year, in place really of the face-to-face meetings that we have had for many years. With lockdown and COVID, of course, we've not been able to do that anymore, but we started these virtual clinics and they've been very successful. And so even I think when we can meet face-to-face again, we were running these clinics regularly. We've covered a whole range of topics over the last 15 months or so. And tonight's virtual clinic is about eye injections. Now, you may know that there are a number of macular conditions: age-related macular degeneration, AMD, diabetic macular edema, macular disease caused by short-sightedness, it's called myopic maculopathy, and even blockages in the veins, the retinal veins at the back of the eye. All of these conditions can be treated with drugs that have to be injected into the eye, into the back of the eye. Now, of course, we're all very grateful for these drugs because over the last 13 or so years, while they've been available, they have undoubtedly saved the sight of many tens of thousands of people with wet AMD in particular. But of course, they have to be injected into the eye. And that, of course, can be a very scary thing, particularly while you're waiting for your first injection. I think many people become quite relaxed and less anxious about them as time goes on. But we also know that even people who've had many injections over many years still feel anxiety about having them. And of course, we know that the clinics are so very busy, and often it's quite difficult to find somebody to talk to, a clinician, to talk to about what is happening and why these injections are necessary. So this evening is an opportunity for a bit of a deep dive into eye injections. And our guest this evening is Gavin Kissoondeeal, who is an advanced clinical practitioner and a lead nurse based at what is called Moorfields South. And these are the Moorfields clinics that are run in Croydon and Purley. And we know that many nurses give eye injections now, and in fact, the NHS couldn't do without them. And we also know that many patients infinitely prefer nurses to be giving these injections. And so Gavin is one of the leading nurses in the country who has developed the protocols and systems for using injections throughout eye clinics here in this country. So I'm going to hand over to Gavin, who's going to take you through a lot of the processes about why injections are necessary and what happens at an eye injection. I'm going to warn you that he has got a few slides that give close-ups shots of eyes during the procedure. Now, I know that lots of people are very interested in what happens during the injections, and that's why Gavin has included these in his slide presentation. But I also know that some people can be quite squeamish about eyes. So Gavin is going to give you a warning when these slides are coming up. So if you are interested and you want to learn more about what happens precisely during an eye injection, then keep watching. If you'd like to look away, as they say, while those few slides, just 3 or 4 slides are shown, then we'll give you a warning so that you don't have to see them if you don't want to. Okay, so I'm going to hand over to Gavin. Gavin, thank you very much indeed for joining us this evening. We're looking forward to your presentation and all of us learning more about the whys and wherefores of eye injections. So thank you very much indeed. And I'm going to hand over to you so that you can share your slides now. Thank you.
Thank you, Kathy, and firstly, thank you for inviting me. I do feel like an imposter because I'm just covering for my colleague Adam Apani as he couldn't be here. So this is I'm just going to share my screen now so that the slide can come up. As Kathy mentioned earlier, there will be a point where some of the slide will be quite gory, so I will let you know in advance. And if anybody wants to look away, please do so. Can I just check that you can see the slide at the moment, everyone?
Yes, we can. Thank you. Perfect.
Perfect. Thank you. So as Cassie said, my name is Gavin Kissoondeeal, and I'm an advanced nurse specialist. I'm based at St. George's. Sorry, I did mention we are Moorfields South, but that includes Moorfields at St. George's as well as Purley and Croydon. What I'm going to talk about are the myths, the truth and misconception of intravitreal injection. Being the lead, I do carry out training and teaching for others. nurses as well as optometrists and orthoptists. That this is part of my role, but I also do clinic 3 times a week. So the coming to injection, what the history of it, it was first approved in 2004 in America, and then in the UK in 2008. That's when we first started to use injection. Prior to that, many patients were unfortunately losing their sight because there were no concrete and efficient treatment. At that time, we were doing laser, but there was a pros and cons because laser was causing scar. But since the introduction of intravitreal injection, the success rate and for patients to improve their vision and to maintain their vision has been very good. Just a little bit of background about macular degeneration globally. As you can see, there's about 20 million people who suffers from AMD, those who are age 60 and above. In the UK, on average, we get about 70,000 new patients every year. That was back in 2016. Since the pandemic, I think many of you know that we couldn't see patients during the lockdown. So the numbers are much higher now, but this is just a gross overview as to how many patients that we see every year across the UK. Causes of macular degeneration. The thing is they haven't come up with the exact cause of it, because there are many contributing factors that lead patients to have AMD. The main one is getting wiser in life, which is obviously all of us, unfortunately, do go through this. So people who are in their 50s or 60s, they may develop AMD. Genetics, if somebody has had a family history of AMD, there's a high chance that the person might get it as well. Surprisingly enough, it seems that there are more female than male patients that tend to have AMD. Also, smoking, hypertension, and being overweight are other contributing factors to AMD. So as you can see, the scientists couldn't pinpoint on just one particular cause because there are so many of them, and different patients come with different history. So not all the patients have the same history. Some of them, they never smoke, and yet they develop AMD. So it could be, to different factors. This is just to show how a normal retina, the first one on the left, is a healthy eye. The middle one is when patients develop dry AMD, which is at the moment not treatable, but the vision loss happens over many years, so it's not as sudden as the wet AMD, which can happen overnight. The far right that's the late stage, so that's when AMD has obviously the cells has atrophied, so basically they've been dying, and this has caused a scar. The one below on the bottom right, this is how the wet AMD looked like. Unfortunately, it is quite a small picture, but I will show you some other one where you can see the leakage, how it presents when we look at it on the OCT scan. Why do we use anti-VEGF? Well, mainly to stop the capillaries from growing any further and to allow the body to reabsorb the excess fluid that's been there. I always use the analogy of a flooding. So if you can imagine, whenever there's the seawater rise, when there's flood, seawater rise up and then it goes inland, but it also carries a lot of debris. When the sea level recedes, you are left with debris around. So this is what happens over years, over time with patients that develop drusen. And once this accumulates, then that becomes scarred. So the injection slows this process down. And also it helps to preserve any residual vision that the patient may have lost or may have still, depending on when it happened. When we see patients in the clinic, some patients would have lost some vision already, unfortunately, but when we start the injection, that will help it might help to improve the vision a bit, but the main purpose of the injection is to slow the disease progression and to allow the body to heal itself. So this is a picture. So the one on the left is the dry AMD, which at the moment, as I said, there's no treatment for now. The one on the right, you can see there's some red zone, a semicircle there, so that's where the bleeding has occurred. And on the corner, the shiny white bits, these are the drusen's, so which is scarred up over time. This is a scan of a patient that we've been seeing for some years, but unfortunately the patient, well, she's been discharged now because we couldn't do much for her vision. But if you can look at the scan, there's on the left there, you can see the green line, and then the one on the right, there are tiny black dots there. So those black dots are actual bleed, so they are blood or fluid, if you like. So this is what we're trying to aim to treat with the injection, try to get rid of the fluid so that then it looks like the one on the left. Most patients knows that with AMD, they tend to lose their central vision. So because of the macula being at the center of the eye. And this is just a quick cartoonish view as to how the disease manifests. But some patients, they don't obviously have the black spot, they have a blurry spot in the center instead. So all varies, but this is just an overview of how some patients perceive their vision. And this is another example of when patients lose their central vision. You can see in the middle there, patients have to, when we do the eye test, we can see some patients start to turn their head sideways. So this is what we call eccentric vision, because the central vision is blurry. So the brain adapts by making the person turn slightly sideways, and that helps to get some better focus and clarity. This one is a perception of one actual patient that I've been treating over the last year or two. So what he tells me that he can see on the picture on the right is in his house. He can see the zigzag line there. So this is what he sees whenever he looks, he stands from where he's standing. This is how he described, he can see the shape and the distortion at home. The one on the left, that was on a nice summer day, and he was riding a bike. And then just as he was coming to this bend, he told me that this is what he, because he was an artist, so he drew. He took a picture and then he drew on his computer what he could perceive. But also he did admit that he was coming from the pub and he had a few pints whilst he was riding his bike. So I'm not sure how much this is optic illusion or how much it is his actual vision. But anyway, it was good to see his perception of what he sees in his life. A lot of you have heard about injections. So these are the common ones, the top three: Eylea, Lucentis, and Avastin. I think many of you have heard. A lot of patients tend to associate price to those injections. So Avastin, I've once been told by a patient, "Oh, you're not giving me the cheap one, are you?" And I said, "No, they are all as efficient as each other, but with some side effects." But the less common one are Macular and Lumentin. Conbercept has been approved in China since 2014, I believe, but Moorfields, they are undergoing a trial at the moment to see the efficiency of it. So just watch the space. You will be hearing this new injection coming up soon. So these are the ones, the box, well, what they look like. Lucentis. The top right is Osidex. This is a pellet. I just took a picture of it because it was there in the in our fridge. But this is a pellet that we inject in the eyes, and it takes about 6 months for it to be slow release. The others are single injection, and then they last between 4 to 6 weeks or up to 8 weeks. So now so just a warning, as Kathy mentioned. Now the next few slides, I'll be showing how we do the injection. So there will be some close-up of patient's eye. Some of it might be quite gory to some people, so please do look away when I'm going to show the next few slides. But I think that, so for now, you guys are okay. So this is what we use. So we've got the sterile tray, and then the gloves, and then a tray, which a lot of patients hate. But this is what we have to do in order to maintain some sterility. One of the the audit that we did at work was to establish the level of anxiety for patient that was undergoing the injections. As you can see there, needle entry, insertion of speculum, and also waiting for the injection are the highest one, because obviously that's what makes patient more nervous, is waiting for the injection, and also when they're going to anticipate the needle and go into the eye, because most people associate needle with pain. But fortunately, you will see towards the end of my presentation, I've got some witness testimony of some patients. So you can hear from their side of the story how it actually feels like in real. But this was quite interesting to get a better understanding of how patient, well, the level of anxiety of patient, and then what we can do in order to reduce that. So now this is coming up to show the next 3 or 4 slides will be close up of the eye. So please, anybody, if you want to look away, please start to do that now. The first one is when I did this, these are actual patients, and also that's me doing those injections. Numbing of the eye. So after we put the speculum in the drape, so I use a drop on the tip of the cotton bud, press against the sclera, which is a white part of the eyeball, and then for about 20 seconds, just to allow the anesthetic to be absorbed in the eye, so that when I do the injection, most patients might not believe this, but when I do the injection, most of the patients, they don't feel anything. They only feel some pressure. But there are some technique that you have to do in order to achieve that. Marking of the eye is one of the techniques. So there I'm pressing on the eyeball with this blue marker. That tells us how many millimeters we need to inject from the iris, which is for patients who had cataract surgery, we tend to do it at 3.5 millimeter. Patient who hasn't had cataract done, we do it about 4 millimeter. So the marker will tell me exactly how far I need to do the injection. And all of them has to be exactly that. I can't do it 3.6, or I can't do it 4.1. It has to be exactly 3.5 or 4. There, as you can see, the needle is into the eyeball. So that's how we actually do the injection. Some patients who had never had it done has thought that we do the injection on the eyelids or around the eye, in the corner. But this is how we actually, or some of them thought that we took the eyeball out and then do it. I don't know how we could do that, but it's strange to see how patient think. But again, this is how we do the injections. After injections, a lot of patients complain, well, they don't complain, but they say that they see certain things in the eye. Those are black dots, which are what we call floaters, or black circle, air bubbles from the injection. Because when we draw the fluid, bubbles tend to form, but as much as we try to get rid of it by tapping the syringe, there are some tiny microscopic ones that end up going into the patient's eye. And then this is what they see. Apart from being annoying, they don't cause any harm, or they don't cause any pain. The third one that they will tend to have quite often is a red eye. So that's what we call subconjunctival hemorrhage. When we do the injection, or when we numb the eyes, the drop that we use to do that, it irritates the blood, the capillaries that are around the eyeball. When this happens, so there's more blood vessels that surface to the eye on the white part. So there's higher chance of us hitting a tiny vein. And when this happens, apart from looking drastic, but I've got some pictures to show you at the end. Apart from being drastic, or it looks bad, but it doesn't, there's no pain, or it is completely harmless. The last 3 in red are those, sorry, the last 2. If this happened to any patient, I would urge them to go to see the nearest eye casualty, and do not wait, just go and turn them and tell them the issue. So if you have unbearable pain, and after taking painkillers, the pain doesn't go away, you get even worse, and you can't open the eyes and you can't bear it, go straight to the A&E, to eye A&E if you can, because that could be a corneal scratch, which is very painful. And also, if you see like a black curtain effect, so like a curtain literally dropping down, and then you can't see anything, what we call sudden loss of vision, again, rush to the nearest A&E and then get the eyes checked. that could be a sign of retinal detachment, which is extremely rare, but it's good to know in case. So these are floaters, aka black dots. So this is what patients perceive. So they're literally as they are. And as I said, I've got plenty of these because being short-sighted, I was born with them, so it doesn't bother me. But for patients who never had it, it can be quite annoying. But apart from that, it doesn't cause any, and it does disappear because the floaters are debris that are already in the eye. When we inject it, it just moves it around. So that's what patients see. So the motion of the floaters being moved around when we inject the eye. So apart from disappearing afterwards, it just sits at the back of the eye. The next one is if the injector are taking too long, or sometimes if the eyes has been exposed with the speculum in for a long time, patients tend to have dry eyes or watery eyes. So, and it can be quite sore. So then we ask them to use either some more of the artificial drops, or we can give them some ointment to soothe the eye. But this is something that we rarely see, but I have seen my fair share over the last few years. And this is what I was talking about, red eye. So when we do the injection in the corner there, so either you can have a partial one on the left picture, so you can have it just in the corner, or you can have it all around the white part, the sclera. So this, apart from looking bad, it doesn't cause any pain. Now, the next few are some witness patients' testimonies. So, and I hope that it does work because I did try it earlier. The first one is one, well, all of them are our regular patients, and some of them I've been treating them for about 4 or 5 years. So it'll be good so that you hear from their perspective what it really feels like to have the injection, and also hopefully it will reduce the anxiety and any fears. So let's have a look at this one.
Hello, my name's Paul O'Connell.
Sorry,
and
can you hear that, Kathy?
I'm a
Yes, we can hear it. Thank you.
Thank you.
Leadership coach and consultant. Now that's a tricky question. It's been quite a while. I'm going to say it's probably been for at least 4 years. Well, the experience of the benefit of them has been fantastic. So it's really helped my eyesight, and it's helped it. I guess it improved, really, is what I would say. And then my experience of having the injections has been the first time I wasn't sure what to expect, so it was a whole new world. And I was kind of wondering, oh my God, an injection into the eye, what's that going to be like? And yet, with the staff here, it has been so easy. I remember and funny enough, I was just talking about it with the gentleman who just gave me an injection, and I said to him, I remember the music that you were playing on that very first day, and it was actually an environment where they make you very comfortable. It's obviously, it doesn't feel like a natural thing to have an injection in the eye, but it was far easier. And it was pain-free. In fact, the only thing that it did to me, it was my mind was making up more of a story than the actual experience was, and it was very easy. And now I now have them pretty much every 8 weeks, and it's not a problem at all. Well, I think, and my tip would be, don't let your mind get you carried away with worries. Because the staff here know exactly what they're doing. It is very easy. You don't feel it at all. And so really, I think the only thing that for me ever got in the way was when my thinking took me. The actual injection itself was always incredibly easy.
Thank you. And then the next one is another nice lady that's
Mrs. Frida Keats. Since 2015, I think it was about September time, 2015. It must be about 36, I think. They're quite easy and relaxed to have. If you relax when you're on the the bench sort of thing, when you're going to have the injection, if you just plainly relax and let yourself go, you don't feel the needle or anything, because you're already numbed, the eye is numbed, and before they put the injection in, they always put some little instrument on your eye to see if you can feel it. And if you can feel it, they wait longer. But if there's not much feeling there, you have the injection. Well, just go for it and let it happen, because it's going to improve you. You know, I think it's a good thing to have these injections. And there's no problem to them, really, you know, no problem at all.
And then the last one, this one, take about a minute.
My name's Giovanna Bozzi. I think I've been a patient here for about 2 years now. I know exactly how many. I've had my 21st today. Yeah, it's just a little bit of dryness afterwards. But I think now I get my eye flushed a little bit more so after the injection, and that tends to alleviate the sort of itchiness afterwards. Just relax, because there's nothing to worry about. I think I was very apprehensive the first time, obviously, because nobody wants to experience a needle in the eye, and it is, you know, quite a big deal. But after I had the first one, I was absolutely fine.
Okay, so these are three patients that has been having injection for quite a number of years, and as you can see from their testimony, that the main thing is to relax and try to not let the mind take over. But I know it's easier said than done. But one of the things that I do at work is we play music, piano or jazz or whichever, soft music, obviously, no rap or hip hop. But it's just to help to create this. As you heard from the first patient, that was the thing that helped him to relax, and obviously that was the thing that he remembered, and that's been over 2 years ago. So we do take extra precaution, and we do whatever we can in order to make it as bearable and as painless as possible. Of course, we can never guarantee that, because no two injections are ever the same, even if it was done by the same person. But we do all we can to try to make it as easy as possible. And now, these are something that I wanted to share with you guys as well. So these are the new treatment that's coming up. Abicipar, so you get sunitinib, which could be here 2023 or 2025. Stem cells has already been tried and still undergoing trial. Gene therapy is a new one. So I've showed just a quick picture as to how they inject the gene into the back of the eye. Beovu, I think some of you may have heard this already. There are some slight reservation with Beovu, but still, I mean, it seems to last up to 16 weeks, I think. So which is quite good for patients, but only certain patients can have that. Eye drops, they are working on some eye drops at the moment, but they've tried it on animal already, and it seems to be successful. So they need to still try it on humans, and so that then to see the efficiency of it. Tablets or pills, they are working on this as well. So this is something to look out for in the near future. Port delivery system, as you can see in the picture on the top there. So they surgically implant this port there, and then the injection get topped up every 6 months or so. So this is something that they are working on, and Roche is doing that, and it seems to be quite successful so far. Lampalizumab, so this is something that will be music to the ears of patient who's got geographic atrophy or the dry AMD. So this is a possible injection to treat the dry one. So that might be coming up in the next 3 to 5 years or so. So again, this is quite promising. So the number of patients in our clinic will suddenly increase. But anyway, that's what we are there for. And these are the new injection device that we haven't used yet at Moorfields, or the one where I'm based, because I'm not very big fan of them. But this, instead of using the drape or the stuff that we currently use, this is just a device that you put the needle in the syringe, and then you just put it on the eyeball, twist it, and then you do the injection. Same to the one at the bottom left one, not same, slightly different. You have to make sure that the eye doesn't move, and the way it's done, it looks a bit more fiddly than the intravitreal. But again, those things we haven't been using this yet at Moorfields. Multivitamin supplements. I know a lot of patients do ask me about supplements, and also because they feel that they already take a good balanced diet. I always tell them there's no replacement of proper fruit and veg. No pill will ever replace that, but people who doesn't like fruit and veg, obviously there's the supplement. But, big but, please be careful. Anybody who has smoked or who is a current smoker, please do not take any of the supplement that has got beta carotene. Obviously, there has been some research done, and then the risk of lung cancer. So the ARIDS 2, they're the one that doesn't contain, but there are many supplements out there that doesn't have beta carotene. So next time when anybody is trying to buy off the shelf multivitamin supplement, please do check those on the box. Well, thank you. That's the end of my presentation, and thank you very much. And obviously, any question, please do ask. I'm just going to go back to my slide there. There you go. Is that all right, Kathy?
Yes, you've returned to us. Thank you very much indeed, Gavin. That was, oh, you've disappeared again. Thank you very much indeed. That was lovely. So you can put your questions into the chat function. We've got half an hour, very nearly, in time to answer any of your questions. So while you're putting your questions into the chat function, Gavin, if I can ask you a little bit more about these injections. So you explained to us beautifully about what the injections do. Why is it that, and you talked about just now about the possibility of the research that's going on into trying to find a way of turning this this medicine into an eye drop that people could put in themselves. They wouldn't have to go to the clinic. It would be the holy grail, I guess, in many ways, wouldn't it? Why is that so difficult to achieve, and why do we have to have this needle business at the moment? Why is that?
But firstly, before I answer that, Kathy, I'd like to thank my good colleague Marcus Peterson, because he is amazing, because he's the one that put all of those patient wishes and video together. Without him, there wouldn't be any presentation. So a big thank you to him, because, and I think I hope he's one of the participants there too. But anyway, but thank you, Marcus, for this. The good question, Kathy. One of the anti-VEGF is a drug that stops blood vessel capillaries from growing. So if this is injected anywhere else directly in the vein, or it is given anywhere else, it will block all the blood vessels around it. So that's why giving it in the eyeball is contained gel, so it is self-contained, so it doesn't go into the bloodstream as such. So that's why it is deemed safe to have injection compared to having it anywhere else. But as you can see on my nearly last slide, they are working on the drops. They are using Cusopt and I think Dozolamide, I think something else, to try to see if they can use the drops in order to help with AMD, as well as the pill. So because obviously the composition, or the molecular composition of the tablets will have to be different to the injection, so that it doesn't seize the blood vessel, because then that can cause complications like stroke and other circulation problems. So yeah, so this is why it has to be in the eyeball.
So the two main reasons then. One is that you don't want this drug to have a systemic effect around the whole of the body, because it could interfere with blood vessel development. We need healthy blood vessels across the whole body, and this VEGF, this vascular endothelial growth factor, is what promotes the body's generation of healthy blood vessels. In the eye, for some reason, it causes these unhealthy blood vessels. So we don't want to give the drug systemically, because that might damage blood vessels in other parts of the body. There's this other thing about the eye being this really cleverly designed capsule, isn't it? So it's actually designed to stop foreign material at the front of the eye from getting to the back of the eye, and the eye drops technology has got to overcome those natural barriers, hasn't it?
The main barrier it has to overcome is for the cornea, which a lot of it drop at the moment already do, because the drops fall to relieve pressures in the eyes, or if we need to give anti-inflammatory or antibiotics, so that it does go through. But yes, they will have to work on a different type, similar mechanism, but obviously to target the very back of the eye. And as you quite rightly mentioned, the eyeball being self-contained, so it is like a protective mechanism, and which is why injection works very well to do that. But the scientists are very clever, so they are coming up with ways of getting the molecule to diffuse through osmosis in order to try to get through the cells. So yeah.
So on the basis of this capsule of the eye capturing basically the medicine and stopping it spreading outside the body, somebody has asked you, it's a very good question, this, if you have an injection in one eye, does it affect the other eye? No. There is a belief that it goes in one eye, it can go disease progression, because the blood vessel, the body, the two eyeballs, they are two organs that's linked to the whole body and the face and everything. But the injection, when we do it, it's just self-contained in one eye. It doesn't go into the other one at all. Okay, so somebody has asked about the speculum, I think it's called, isn't it? The device that holds the eye open for the procedure. Can this do any damage over a long period of time? If you're having this day, month after month after month, does it have any damage? Long-term use of the clip, people have described it as the clip, but I think the question is actually about this called speculum. Could it affect the eyelids, for example? Not to my knowledge, but I have come across very few patients that have told me that they've noticed the eyelid drooping down more over time because they've had so many injections. Now, this could be with elasticity of the skin, that's why the lids drop down, or it could be when the speculum, if is left there for a long time, each time they have the injection, then that can interfere with the muscle elasticity, if you like. But as far as I know, no, it doesn't. But the thing that it can cause, more on the short-term one instead of a long-term, is corneal abrasion. Is when this is put in, if the injector is not careful as to how they are scooping the lid, the top lid and the bottom lid, then that can cause abrasion. And also when it is being removed, that can also cause abrasion, because if they remove it and they don't squeeze it properly, it can scratch the eyes quite badly, and it's very painful. Because, well, I've had it myself. So yeah. Yeah, and we have had a question about that. Somebody who had exactly this experience of corneal abrasion, although the pain actually only happens 3 days after the event. Is that a normal thing? Would that be to be expected? I mean, you might not notice it immediately. Presumably, you've still got some anaesthetic, haven't you? No, the pain will start to happen like a few hours after you get home, because from the time we put the anaesthetic in, so that will last for about 2 or 3 hours. So by the time they get home, they will start to feel some pain, but it depends on how bad it is. You see, a small abrasion is not going to be that painful, and some patients high pain tolerance can bear that. But I wouldn't, because I've got a low pain threshold. But it won't be after 2 or 3 days. It will be within the same day or the next day, depending on how bad it is scratched. What could cause pain 3 days later, then, do you think? 3 days later, that will be the iodine, the reaction to the iodine, which can carry on during that time, because the iodine is very toxic. It kills off all the bacteria and bugs, but also it kills off the good cells as well. So, and whenever we use iodine, it can go at the back of the eyeball. And I always tell patients to use the drop every hour on the day of the injection until bedtime to help flush some of the iodine. And as you heard one of the patients, the last lady, Bossy, said, what I've been doing, because she's been having this kind of problem, so I've been washing her eye with saline straight after the injection. So this is something that we tend to do now if patients
continues to have those experience to have irritation that goes on for more than 1 day and 2 or 3 days. So this is something that can be rectified, if you like. So if they tell the injectors or tell the people there at the hospital, then they should be able to flush the eye a bit for them.
We do hear occasionally of patients who say they do suffer very considerable pain on injections. Most people don't. That's clearly the case, but we do have people who say they do have regular pain.
Yeah, that's true.
And it is likely to be the iodine, is it? Is there an alternative to iodine?
Yes, there is an alternative which we don't like to use, which is chlorhexidine. The efficacy of it is even less, half of iodine, and there's a higher risk of infection if the patient, or if after having injection, patients are not careful to keep their hands clean, or they touch some dirty surface and then touch the eyes when they do the drop. So because of that reason, we don't use chlorhexidine regularly, only to patients who are, well, allergic. Not many patients are allergic, they are just sensitive to iodine. But the pain factor will be, if it's to do with injection itself, then that will come down to the anesthetic. So it's just making sure that they put enough, or they leave it long enough. But in theory, it's the iodine that will cause more irritation for longer. But injection itself, once injection is done, the eye has been bruised and battered. On that day, after some painkillers, hopefully that will help. And the eye is quite tough, and it heals quite quickly. So, but it's good to talk to the nurses or the injectors over there for those patients who really find it really painful, because then there could be other things that they can do, as I said. So the iodine is one of them.
Okay, that's good. Thank you very much. So a question here about somebody who experiences quite a dry discharge in the eye, very much like after sleep, having had some hours after having had an injection. And I think the concern of this person is, does that mean the eye is rejecting the injection liquid drug in some way?
No, that's probably when the eye drops, because it's quite viscous. When it dries up, maybe it goes some dryness, some flaky on the eyelashes, but no, it doesn't. The injection cannot be rejected by the eye this way, because it goes straight into the gel inside the eye, so it doesn't come out as such. So it doesn't work in this way, if you like. But that's with the other drop, or the drying of it drops more likely.
Right. So the drops. It's the dropped fluid from the drop that's
because
dry.
So when it dries up after somebody has slept for some time, then you will feel there's some flaky stuff there.
Yeah, that makes sense. Another question about if you have a bleed. So this is when these abnormal blood vessels, they leak and they bleed. If that happens after an injection, does it affect the effectiveness of the drug being administered? I guess the question is if it happens sort of around about the same time. I mean, it could just be that it's a coincidence that one would happen at the other. Does it mean the drug has been won't work as well, I think is the question.
Well, if they have a red eye during the injection, or is that what the question, or is it having abnormal blood inside the eyes?
I think it means inside.
But the injection will carry on working, because the body will keep on healing itself, so it will keep on growing those capillaries, and which is why a patient needs to come every 4, 6 weeks or 8 weeks, just to have this regular top up in order for the molecules to bind with the receptors inside the eye to stop the formation of the capillaries. So irrespective if the capillary is still growing, you can still have the injection and it will still work anyway. So that shouldn't cause any negative effect.
Okay. I hope that answers that question. But if I've misunderstood your question, do put in an explanation in the chat. We'll come back to it. Just going back to the iodine very quickly. I've got a question on floaters in a minute, but just going to the iodine, back to the iodine for a minute. A question here is, does it actually enter the eye itself? In other words, does it enter the eyeball? I think it means. The question means. So it's just on the surface of the eye, isn't it?
The iodine is used, we use it only on the surface of the eyeball. So it goes inside underneath the top and the bottom lids, which why it goes irritation after the injection, while some patients have this sensitivity towards iodine, but it doesn't, we don't inject it directly or inside the eye as such. It just goes outside the eyeball.
Okay, so the question about the bleeding is actually about blood in the sclera. So if the eye is bloodshot, does it mean that it's
no,
rejected?
it doesn't mean any negative effect to the injection. The injection will still work and will be still effective as it would be, because the injection is the drug is inside the eyes and the one, the sclera, is outside. So that would not cause any problem at all.
Okay, thank you. So a question here about why are the air bubbles black? Now, I think you talked about two things. You talked about air bubbles and you talked about floaters. So can we just go back and recap on both those things, the bubbles and the floaters?
It's just the light rays, the way it bounces, because it is a transparent circle. So when the light bounces, the reflection, when the light goes in and bounces back again, it creates this shadow. So that's what they are seeing with black circle instead. So it's the shadow that it is, that's the light when it bounces back. And the same with the floaters. So these are debris of vitreous gel that get detached over time. So when the light reflects back on it, then it looks like a black line or a black dot.
So I'm short-sighted too, like you, and I've always had lots of floaters, and they look grey to me. I have to say they look a bit sort of like tadpoles or things that are sort of swimming around, but mine don't tend to be black. They tend to be grey.
Where somebody is looking, the background that they're looking at. So if they're looking in the sky, they will tend to see a different color. If they're looking at a white background, when they look at it, they're going to see it more prominent. So if they're looking at a darker background or different color background, it's all going to be different colors based on what background is against. So it's just an optic illusion, if you like.
And harmless. We don't have to worry about.
Well, the only time that patient needs to worry about floaters is if you get lots of them. I mean, like tens or hundreds of black dots flying around with flashing light in the corner of the eyes. And also if they start to see like again, black curtain effect, this is the only time that they need to worry, and they need to go to the eye A&E straight away. So, but if you get lots and lots of black dots with flashing light and a black curtain effect, that's when. But otherwise, you get just one or two random, or if you up to 5, it's fine. But if you're getting lots more, let's say in tens and multiples of tens, then I would say to get the eyes checked.
Okay, so a question here about how effective the injections are. So what sort of efficacy do they actually offer? How good are they? What difference does it make?
It's a shame I don't have the slide to show some of the statistics. I'd say it's about 50 to 60% efficacy, but depends on the individual patient. Because if somebody has got other contributing factors which will aggravate AMD or which cause the body to develop AMD, then those patients, obviously the efficiency of the injection will be short lasting, so only for a few weeks. And then that's why some patients will need to go back every 4 weeks to have the injection done. Or other patients whose body stabilize the condition better and whose body is healing better, those patients will tend to be seen every 10 to 12 weeks. So that's when you know that your body is doing a great job, the injection is working. That's why we can extend the visit up to 12 weeks or more. But if we are having to see you every 4 to 6 weeks, that's when we know that the body is not able to keep the healing process going for that long time. And then that's why it needs the booster, i.e. the injections, to help to stop the blood vessel from growing.
So I think certainly for Lucentis, I think the pivotal, as they say, the so-called pivotal trials that were the trials that led to it being introduced as a licensed drug, showed that about 90% of people got some benefit from it, but there's about 10% of people who don't seem to respond well to these injections at all. Is that still I think that's still the case. Is it with the newer drugs as well?
Well, with the newer one, we don't look like the Biovu, and we don't quite. They're still doing some trial at the moment, just as All Street, Moorfields. But the literature that I've read, there's a 10% chance of patient developing vasculitis, which is an inflammation of the eye, as compared to, let's say, 0% or 1% with the other injections. So as much as the other one seems to, they say it can last longer, but there's a higher risk. But in terms of the current one that we are using, I think Lucentis, because the fact that they did make the molecule that much smaller, it absorbed better. So then a lot of patients did find the benefit, because it was just to do with the way that they divided the molecule itself. Avastin, which was bigger molecule, not many patients were benefiting from it. On the contrary, they were having more side effects in terms of problem with the heart or other circulatory problems. But in terms with Eylea, they've managed to combine not one, but two separate molecules, which is why, yeah, it worked, but then it lasts longer. On top of working, it just lasts that much longer. So all of these companies, they have, it's a trick of a trade. So they have one or two things that they will focus on in order to say, yeah, their product is more beneficial than others. But from what I've seen, a lot of the patients are not having Lucentis, because we are using Eylea instead, just purely because it means less and less injection over the years. Lucentis, every time a patient have an injection, it carries a risk of having any eye infection anyway. So every time we inject the eyes, this risk still stay the same. So less injection, which means less risk for patients. So this is how we tend to look at it instead.
And really, some of these drugs that are coming through now, like the Roche the port delivery system that Roche have got Roche, to try to extend the intervals between injections even more. That's a great boon for patients. It's also a great boon for the NHS, because the clinics are overwhelmed, aren't they? So if we can extend the period, I mean, somebody has just said they've had 120 injections, and that's now common, isn't it? After 10 or more years, when people are really having frequent injections now. So somebody has asked about the second eye involvement. So people are having, if they have wet AMD in one eye, there is a significant chance, isn't there, that they will develop it sadly in the other eye.
50% chance that it can happen into the other eye. Yes, unfortunately. Yeah. Which is why we tend to advise patients on their lifestyle. So smoking cessation, and also if a lot of patients in that age group will tend to have some blood pressure issues, which will have hypertension, which will affect AMD. So they have to maintain good control and keep taking their tablets. And also change of diet is very important, because we see the green vegetables and lutein and zeaxanthin are the best antioxidant in order to help cells regeneration as well. So it's a combination of different things in order to help the prevention more than anything else. But a lot of patients that I speak to every day at work, they say, well, I already eat kale, I already eat spinach, I already do that, this, that. But it's good, but then it's other factors which has caused it as well. So
certainly smoking is terribly bad for eyes, isn't it? It really
the eye needs more oxygen than the lungs and the heart to function. People would think that our lungs and the heart needs more oxygen, but no, it's the eyeball. So with smoking, we find that the level of oxygen that gets sent to the eye reduces, which is why patients develop this condition as well as other contributing factor. But smoking is one of the big problems, if you like. But then the smoking is for every other condition as well. So it's not.
You can imagine if it damages the blood vessels in your heart, it's certainly going to damage the tiny blood vessels in your eyes, isn't it?
Yeah, exactly.
So another question here. So yes, it is true that there is a 50% chance of developing AMD in the second eye within 4 years. I think that is the generally accepted statistic, isn't it? A question here about diabetes. Does diabetes we know that diabetic macular edema is treated in the same way very often. Does the diabetes make it even more complicated and problematic for the body to heal?
Yeah, because with diabetes, you already have frail blood vessel, because diabetes affects the circulation everywhere, and also it delays healing a lot. As a lot of diabetic patients know, if you have a cut or a bruise somewhere, it takes that much longer to heal or for the blood to stop. So the combination of that, as well as getting wiser in life, if you like, the two works against the patient, because the two are degenerative conditions, two in one anyway. So apart from just having AMD, having diabetes is a shame. But the thing is, a good thing is if you maintain very strict control of the diabetes, because there's, surprisingly enough, there's a lot of patients that has cured themselves from diabetes by changing the lifestyle and diet. So there is always glimmer for hope. It's just that we have to be very, very strict in order to maintain the stable, for the condition to be stabilized, like. But it is quite bad luck to have the two together.
Yeah, I don't think this person has. I think it's just being treated for diabetic macular edema, but just the diabetes will compromise the situation, I imagine.
Yes, yeah. I mean, because you do have diabetic macular edema as well as AMD, but this because it manifests in similar ways like the AMD. So yeah.
Yeah, and curing diabetes, somebody points out quite rightly, type 2 diabetes people have done, but not type 1. Now we're beginning to run out of time, so I'm just going to whiz through the other questions pretty quickly now. So somebody points out that some clinics give antibiotics after injections for 4 days, and some clinics don't. So why is there a variation in that area?
The latest research that we went by, that was about I say latest, but that was about 6 years ago. It shows that instead of helping and preventing risk of infection, it was causing the patient to be to have some negative effects. So they are becoming resistant to the antibiotics. So then, if they had an infection, then we wouldn't be able to use the antibiotic that we could have used instead. So the research did show that by not using antibiotics and using it, the outcome is the same. So that's why we've chosen not to use antibiotics, because we don't want to put patients at risk by overdosing them, if you like. So this is a practice that in theory they should have stopped. But anyway.
All right, so that's something to challenge the clinic on. And finally, I think we'll have to finish with this question about Avastin. So Avastin was the first drug really that was ever used in AMD, and it was a repurposed cancer drug, wasn't it? It was originally designed as a cancer drug, designed to stop the blood supply that grows is necessary to support the life of a tumor. And this drug was designed to stop the blood vessels that grow to support a tumor and therefore prevent it from growing. And somebody thought, I wonder if it would work on the abnormal blood vessels that grow in macular degeneration, and it did. And Lucentis came out of that sort of stable, didn't it? It's as you said earlier, a shortened form of Avastin, and it is still used, Avastin. And so the question is here: is it as safe? Is Avastin as safe as Eylea and Lucentis?
Yes and no. Yes, a lot of patients, I inject Avastin to quite a few patients, and the patients are fine. So it depends on the patient as well. So it is safe. No, when I say no, is when they did the trial, they found that Avastin has got a slightly higher risk of causing other issues, circulatory issues, as compared to Eylea and Lucentis. So that's what the research showed. But in reality, when we've been using it, we found that it is equally as safe as the other two on certain patients.
Okay, thank you very much indeed, Gavin. That's, I'm afraid, regrettably, all we've got time for this evening. But Gavin, thank you very, very much indeed for your time and for such a great presentation. Next month, our guest for the November, I can't believe it, November virtual clinic is Professor Luminita Parowan. Now, Luminita is the chair of the Macular Society Research Committee, and that is the expert advisory panel that assesses the applications from research teams to our research grant program. So she has a bird's eye view of all the research that we're funding at the moment. It's the committee's job. They make recommendations to our board of trustees as to which research teams the society should fund. So, as I say, she's got a first-class view of the research that's currently underway. She is herself one of the world's leading molecular biologists, and she heads up the ocular molecular biology department at the University of Liverpool. So she'll be talking about her research into AMD and also what is on the horizon. So that's the November virtual clinic on Tuesday, the 16th of November at the usual time of 7 o'clock. So tonight's virtual clinic has been recorded. It will be available on our website, through our website, and on our YouTube channel. If you just go to YouTube and Google Macular Society, you should be able to find our films and all the virtual clinics. So if there's somebody you think would benefit from knowing about this, please do tell them about it. And if you want to watch it again in a couple of days, it will be up on the website again. If you want to, you say, I might have missed something special by not seeing those close-ups of the injection going on, and you might brace yourself to want to look at it another time. But in the meantime, thank you very much indeed again to our guest, Gavin. I'm so grateful to you. I'm grateful to everybody for joining us this evening. Have a very good evening, and I hope we'll see you next month. Thank you. Good night.